wait. Well, good morning. Thanks again, Mark, and to all of you for being here. It's a real pleasure to be on this panel. I've been tasked with discussing the optimization of the patient and the surgical environment to reduce prosthetic joint infection. I do have some disclosures to point out. Moving past those, I think the best way that I like to think about patient optimization is to think about the continuum of care. So what are the things that we can do in the preoperative period, things like risk stratification and optimization of those risk factors. Then I like to look in the perioperative period. So what are the things that we're doing in the operating room immediately before they get in the operating room, immediately after, and then at the end, after surgery, what are the things that we can do to mitigate what we know are some other risk factors in that postoperative period. So we'll go through several of those areas and hopefully give you an overview of how I like to approach this. So I do think that the first step is really understanding what the risk factors are for your patient. There have been a whole lot of studies that have looked specifically at this, and we know there are a whole bunch of different risk factors. I think it's helpful to look at those risk factors as either modifiable or non-modifiable. So unfortunately, a lot of the risk factors that we're aware of are actually not modifiable. So we can't really change someone's race, their gender, their socioeconomic status. But we can really focus on these modifiable risk factors. Things like obesity, their glycemic control, their nutrition, whether or not they're using nicotine products. And when I'm counseling patients in the preoperative period, I talk to them about this modifiable versus non-modifiable risk factor. And I am very clear to point out that a risk factor may be modifiable, not necessarily easily modifiable. We all know that obesity is not necessarily easily modifiable. Nicotine use is not necessarily easily modifiable, but it certainly is something that they can change if there's enough desire. So decolonization, I like to start there. We know that 25 to 30% of patients who are going to have a knee replacement or a hip replacement are colonized with Staph aureus. There have been several studies that have looked at decolonization protocols that have been effective at reducing SSI. A couple of those use chlorhexidine gluconate and nasal mupirocin. This was a study done at Washington University where they looked at treat all protocols versus screen and treat. So the idea there is if you screen everybody that's coming in, culture their nares, and if they're positive for Staph aureus or MRSA, then you decolonize those patients. When they compared that cohort to a cohort where they had actually treated everybody, they found that the treat all protocol actually resulted in fewer infections and, interestingly, lower cost. The cost of actually doing the decolonization is fairly inexpensive. It's just a minor bump in the cost of, the total cost of a joint replacement. So treat all protocols seem to be what's come into vogue and really supported by the data. This is what we're doing at our place now. We don't bother screening, we just treat everybody. So obesity is one of those risk factors that unfortunately I spend a lot of my day talking about when I'm in clinic seeing new patients. Again, many studies have demonstrated that obesity is a potent risk factor for PJI, and it seems to be beyond linear. It's almost like if you plot out the curve of infection versus PJI, once they start to get above 40 or 50, that risk for prosthetic joint infection really starts to climb. What's interesting is we do know that obese patients actually do very well after joint replacement if they don't get an infection. Their satisfaction and functional improvement is as well, if not better, in several studies compared to non-obese patients. I think the bigger question is, how about short-term weight loss? Does that help? And it appears that short-term weight loss probably is not protective against prosthetic joint infection. This was an interesting study. They looked at a large database cohort, and they looked at patients who had a BMI of 45 to 50. And if they had weight loss more than a year before their surgery, that was actually protective against prosthetic joint infection. But what was really interesting to me was the cohort. So they looked at a cohort who had weight loss in the 3 to 6 month range prior to surgery. that was actually the highest risk cohort. They actually had a greater risk of prosthetic joint infection than the group that didn't lose weight. So it appears that while weight loss can be beneficial, the timing is probably important. And I think this leads to the idea that patients come in with a BMI of 50, we tell them they have to get to a BMI of 40 or whatever your number might be, and they go on some drastic diet and they become malnourished, and then that increases their risk of infection in the short term. If they can do it over a long term, it's probably a healthier way to go. So that brings me to the nutrition aspect. What is fascinating is if you look at obese patients who are undergoing arthroplasty, almost 50% of those patients are malnourished, what we would call paradoxical malnutrition. This appears to be because the way their diet, the way they consume calories, it's a lot of calorie-rich but nutritionally poor foods, so lots of fats, sugars, low complexity carbohydrates. But I think beyond those patients, you have to pay a special attention to the elderly, patients with substance abuse history or substance abuse disorders, patients with GI problems who are malabsorbing vitamins, and then lastly, cancer patients. That's a particularly high-risk group, so pay close attention to those patients when you see those. Numerous authors have looked at how to screen for malnutrition. I think the most commonly used tool right now is probably albumin, but I've listed several here. Total lymphocyte count less than 1,500 has been used by several authors, and a transferrin level less than 200. So just any of those patients at risk ought to be screened, and if they screen positive, then you can refer those patients on to a dietitian to work on their diet prior to joint replacement. Well, what about glycemic control? Again, this has been studied extensively. There are a lot of studies that have looked at, is hemoglobin A1C a valuable marker as a risk factor for prosthetic joint infection? It does appear to be helpful. There's not a great cutoff point. You can look at 7.5, 8, 8.5. There's a lot of debate. I don't think the literature is entirely clear. What we do know is glycemic control is important. People who have poor blood glucose control, especially around the time of surgery, are at increased risk. So a couple of interesting studies looked at patients with a diagnosis of diabetes, and they compared those who were well controlled to those who were poorly controlled. And as was a surprise to no one, is the poorly controlled diabetics had a higher risk of prosthetic joint infection. But what I found interesting is patients with well-controlled diabetes actually have no real increased risk compared to healthy controls. And another interesting study found that even patients who have never been diagnosed with diabetes, if you look at their perioperative blood glucose, so if in the PACU they have a blood glucose greater than 140, that cohort's at significantly increased risk for PJI. And that literature actually has been, or that data has been extrapolated in multiple surgical disciplines. So we know in ICU patients, cardiac surgery patients, general surgery patients, trauma patients, they all have increased risk of surgical site infections if they have poor perioperative blood glucose control. Well, nicotine is one of those that also seems to be a difficult conversation for many of us. There have been several studies looking at this. I think this meta-analysis was really helpful. They actually found an odds ratio of 3.7 for PJI risk in patients who were using nicotine. Again, similar to weight loss, smoking cessation does appear to reduce the risk of prosthetic joint infection, although they looked at this at the University of Iowa and in a very large database study and found that former smokers compared to non-smokers actually had increased risk of infection. So that was a database study, a little bit hard to control for how long a patient had been a former smoker. So I don't think there's clear guidance on a timeline, but for me, nicotine use is a hard stop before an elective joint replacement. I just tell the patients, look, there are a lot of risk factors that we can't control, and there are some that we can. This is a risk factor that we definitely can control. It is nicotine products in general. It's not just smoking. So I make sure my patients are completely abstaining from nicotine for 6 weeks prior to elective surgery. And then inflammatory arthropathy. So fortunately, the advent of a lot of these medications the rheumatologists are using now seem to have helped tremendously with patients suffering from inflammatory arthropathy. So we're actually seeing a lot fewer of those patients needing joint replacements. But there are still some, and I think, you know, as the number of medications that come out to treat rheumatoid arthritis and other inflammatory arthropathies just explodes, it's a bit dizzying to the orthopedic surgeon when you see these patients. I mean, it seems like once a month I see somebody who's taking a medication for RA or psoriatic arthritis that I've actually never even heard of. Like, I've heard of the class, but I've never heard of the medication. So the American College of Rheumatology and AAHKS actually published guidelines on this in 2017, and then this was recently updated in 2022. This is a great paper. I would highly encourage you to use this as a reference. They went through all of the major classes of these drugs, and then specifically looked at lupus, and if the lupus was severe lupus, how you adjust the medications. I would say the take-home message from this guideline paper is that traditional DMARDs, so things like methotrexate, hydroxychloroquine, doxycycline, those can be given throughout the perioperative period. There's probably no indication to hold those. Where you really want to be careful are on the biologics, the immunomodulators, and there are different classes of those, but the general consensus is, depending on the dosing regimen, so if it's a 3-week cycle or an 8-week cycle, you schedule their surgery at the end of a dosing cycle and then hold that dose. So if they, take a medicine that's given every 8 weeks, they take their medicine, then 8 weeks later you do their joint replacement. You hold the medication until the wound's healed, and then you can resume that medication, usually safely. So Mark talked about this a little bit, prophylactic antibiotics. There's very clear evidence supporting the use of prophylactic antibiotics in the perioperative period. First or second generation cephalosporins appear to be superior. The current AAHKS recommendations are for a 24-hour period of prophylactic antibiotics. What's interesting is a couple of meta-analyses actually found that there's no benefit to 24 hours of antibiotic therapy versus a single dose. There is a level 1 study that just completed enrollment at Duke. We're waiting on that data for publication, but it appears that probably one dose is as beneficial as 24 hours, but just hold your judgment on that until a little more time and studies are available for review. I think another interesting thing, and this has really changed in the last probably 10 years, a penicillin allergy is not a contraindication to the use of cefazolin. The 2019 Charnley Award from the Mayo Group, they looked at this and they compared patients who had prophylactic antibiotics with something other than cefazolin and those who did have cefazolin. And the non-cefazolin group had a significantly higher risk of prosthetic joint infection. So unless the patient has a true allergy to cefazolin, they should receive first or second generation cephalosporin. If you need additional antibiotics, if they have MRSA, you can certainly add something like vancomycin, but they should also get cefazolin. All right, so what about skin preparation? So there are lots of studies looking at various skin prep agents on the market. There's pretty good data on the use of chlorhexidine gluconate wash in the preoperative period. So our protocol is currently 5 days of chlorhexidine gluconate bath to the affected extremity. We remove the hair in the preoperative area with electric clippers. Don't use a razor. Razors are associated with increased skin trauma, which releases bacteria from the hair follicles, and that increases the risk of prosthetic joint infection. We like to use a combination agent with ethyl alcohol and iodophor. There's also combination agents with CHG and hexachlorophene. All of those seem to work very effectively. The use of alcohol is as a potent antibacterial agent. Those additional medications just help prolong the effective time of the ethanol. I also believe strongly in the use of incised drapes. There's some data supporting this. The use of an iodophor impregnated drape actually has been shown to decrease lateral bacterial translocation in these wounds. And what I like about it, especially in the hip, is it gives us the ability to effectively occlude areas of high bacterial colonization. So we can block out the perineum and the rectum area with these drapes. So I use those routinely. And then we're going to hear a lot about wound irrigation today. As you guys are aware, there's a lot of different solutions that are available on the market. Currently, povidone iodine is the only solution out there with level 1 data. That was a paper out of Rush that studied that. That was in revision total hip and knee arthroplasty, not in primary hip and knee arthroplasty. The one thing I really like about Prontosan is it's the only solution on the market that doesn't require some additional irrigation after treatment. So especially in our current era after Hurricane Helene, and at least in our hospital, and I'm sure with the rest of you, we're being very, very cautious about the use of saline. So we're using Prontosan in all of these cases to avoid the necessary use of saline to try to save that. So what about airflow? So this has been one of those subjects that's been debated back and forth for years. Several laminar airflow studies have shown an improvement in the risk of PJI, but unfortunately several studies actually showed an increased risk of PJI. And Mark alluded to this as well, the OR environment. There are numerous studies that have shown OR traffic significantly increases the number of airborne bacteria in the room. And when you look at door openings in particular, every time the door's opened, it changes the airflow pattern and creates a whole bunch more airborne bacteria. And the majority of those door openings are unnecessary. So in a modern era where we have lots of technology to help, we're able to keep implants and instruments in the room. You really should institute policies in your institution where you're absolutely only opening the door when it's 100% necessary. If somebody wants to come in and check on the nurse to see if they need a break or the circulator, or especially anesthesia in and out all day long, offering to go get a coffee, just really try to put the kibosh on that. We use signs like this in our OR to try to minimize the number of people running through there. Body exhaust suits, this is another one that's sort of gone back and forth over time. We know that most of those bacteria, the airborne bacteria, come from shedding from the OR personnel, so the body exhaust suits were developed to minimize that. They actually are effective at minimizing the number of airborne bacteria. I think the bigger question is, do they actually then minimize the risk of prosthetic joint infection? Several studies have suggested they do not. But what we do know is that it's a very effective fluid barrier, so it helps protect the people in the operating room, and that's really the primary reason that I use. I shared a picture of myself and one of our former residents. As you guys know, these cases can sometimes get pretty messy, and there's lots of blood and fluids flying around, and so just as a way to protect your OR personnel, I think body exhaust suits are pretty beneficial. So this is an interesting topic that's come up recently, extended prophylactic antibiotics. So we're moving into that post-operative period. So we published a couple of papers. We studied the use of extended prophylactic antibiotics after two-stage exchange, and we found that there was a significant improvement in the risk of recurrence in those patients who had a short course of prophylactic antibiotics. So Michael Meneghini and his colleagues in Indiana studied this, looking at the high-risk primary arthroplasty cohort. And so what they defined as a high-risk patient received a 7-day course of oral antibiotics. They did find a significant reduction in short-term infection risks. This was a retrospective cohort study, so actually when you read this paper, they were very clear to caution us that this shouldn't be adopted widely without further level 1 studies. We really need a couple of randomized controlled trials of this particular question before I think this should be adopted widely. Blood management, again, this is something that really has changed a lot in the last 10 years with the advent of tranexamic acid. An allogenic blood transfusion is an independent risk factor for prosthetic joint infection. And we know that restrictive transfusion policies can significantly decrease the risk of transfusion without affecting patient morbidity or mortality. So I think what's really changed about this is in years past when I was training, we had some randomly assigned number, like, their hemoglobin's 10, they get 2 units of packed red blood cells. Now we're really trying to use physiologic transfusion triggers. So even if their hemoglobin's 8, if they're asymptomatic, you don't necessarily need to transfuse that patient. And with the use of TXA, we're seeing fewer and fewer transfusions anyway. I think probably the other thing that's really, really important is screening those patients preoperatively and managing their anemia before they have elective surgery so that you can avoid this risk. Wound management, we know that prolonged wound drainage is a significant risk factor for PJI. So we aggressively manage any draining wound. I think there's some evidence that closed incision negative pressure wound therapy is beneficial in high-risk patients. We recently completed an RCT at our place, and we're still analyzing the data, but it does seem to be beneficial. I think the jury is still out on primary arthroplasty. There's not a lot of level 1 data on its effectiveness in those patients, but there's probably high-risk patients that do benefit from that. It just needs some time for definition. The last thing is anticoagulation. I think you have to be very cautious with aggressive anticoagulation. This is one of those complications that we're trying to avoid. It appears that 81 milligrams of aspirin BID is safe and effective. The PEPPER trial, which many of you are aware of and are involved with, is nearly complete. We're expected to finish enrollment later this year, and so we'll have a good answer on this. I think the real problem is in the patients who are at high risk for DVT and PE, the patients who have poorly controlled atrial fibrillation or have a prior PE. You have to work closely with your medical teams. They all want to put them on a high-dose therapeutic DOAC on post-op day 1, and those patients are at significant risk for bleeding complications. So we really try to negotiate with our internists and really look into their clotting risk, especially if it's AFib. You can look at their CHADS VASC scores, and if they're not super high risk, then you can really dial back on the DOAC to at least a prophylactic dose rather than a therapeutic dose. So in conclusion, I think it's really important to develop systems and processes to screen out those high-risk patients. I think if you can spend a lot of time counseling your patients and really informing them of the risks of complications, that's beneficial. I think no matter what we do, you're going to continue to have some patients with complications. And if you've taken that time and you've really explained the risk to patients, then God forbid when a complication does occur, at least they feel like you've given them all the information they can handle. I think the last thing I want to say is prevention is the best cure. If we can prevent most of these by being smart on the front side, then we can prevent a lot of these complications at the end. So thanks for your time.